And thank you for joining us. We're looking forward to a good show. Thank you so much. And it's all yours. Thanks, Doc.
Okay. Thank you very much. Some of you may have in the mail received one of our periodic research reports. This one is just finished and dated October 21, 2024. It's called How to Stop Deterioration in Adhesive Arachnoiditis. Now, this report is just one of many along the way, but I wanted to say two or three special things about this report. First off, the research and education effort that we started off with about 6 or 7 years ago was focused on adhesive arachnoiditis. We had no idea that we were going to end up taking hard looks at small fiber neuropathies, pudendal neuropathies, burning mouth, fibromyalgia, and a lot of other conditions because we did not know they were related. Now, today, one of the messages coming out of this periodic study and future ones is that these intractable pain conditions that everybody's suffering with don't appear independent, but appear to be connected. And that's one of the things that we're going to talk about tonight. This is going to be a pretty informal discussion, and I happen to know our guest coming has been through a lot, knows a lot about it, and is a perfect person to talk about how these conditions are all related. Now, I also want to say one thing right now. And Dr. Ibsen, I know I'm going to want him to say a few things about this. Those of you who have intractable pain, and particularly things like adhesive arachnoiditis, small fiber neuropathies, pudendal neuropathies, burning mouth, some of these conditions are rare conditions. So there's, compared to conditions with like hypertension or asthma or diabetes, the conditions that of those of you who are watching this and who will watch this after the show or who follow us have really rare conditions or very unusual conditions. So there's not a lot of us. And so therefore, I want to thank those people who participate in our studies. We cannot get information from around the world unless we have people voluntarily, fill out questionnaires, send us laboratory data, send us MRIs, give us information that we can put together and formulate protocols, ideas, suggestions, or new ideas for research. So I want to personally thank everybody who not only participated in this study, but in past studies, and also warn you, I'm getting ready to start phase 2 of the study on deterioration of arachnoiditis. So we're going to be looking for a few more volunteers coming up quite shortly. Now, there are a couple of things that came out of this study. And first off, everybody who participated in this study is getting some medical care. Now, this may sound like a strange statement, but 10 years ago, we had people who could get absolutely no care, no recognition, no concern about their intractable pain conditions, much less adhesive arachnoiditis or Ehlers-Danlos or any of those things. But what we saw in studying these patients who did participate in this study is a lot of doctors and nurse practitioners, chiropractors, and other practitioners who do care. I know today we're very unhappy about the medical system. We see people who you wonder why they bother to get an MD degree the way they act. But we have a lot of really good people out there and a lot of people who care. And we also have a lot of doctors and nurses who want to learn. So I want to recognize something that is not well appreciated in every community in this country. Despite all the politics and all the controversies, we've got some good, caring medical people out there, and I think they need to be recognized. You may have to search for some, because I sometimes do wonder, why did some of these people bother to go to nursing school or medical school? They certainly don't carry the cause like I think they should. That said, again, thanks to those of you who volunteered, as well as we learned in this study that, yeah, there's some good doctors and nurses out there. And I want to tell you one other good thing. I am hearing literally every other day from some doctor or nurse practitioner, even some doctors in pain clinics, for God's sakes, who really are concerned and who do want to learn about the new things in science, about the viruses, about autoimmunity, and about inflammation and glial cells and all the things that we're studying these days. Uh, to go on, I think you need to know why we're studying what we're studying. And it all goes back about 10 years ago. Now, about 10 years ago, what we started seeing in our intractable pain clinic were people who fundamentally had two conditions. They either had adhesive arachnoiditis or their other real pain source was small fiber neuropathies. Severe pain in the joints, the pudendal area, the mouth, the chest, the foot. And we didn't know a lot about either one at the time, small fiber neuropathies or adhesive arachnoiditis. But those two conditions have really now come to the forefront and are really have to be the focus of research. Now, in about the year 2015, a discovery was made, and I may have mentioned it on this show before, but it needs to be said again. And at that time, some brilliant researchers, of which the foremost one was a woman by the name of Linda Watkins, who's a biologist, physiologist at the University of Colorado. And she and her team discovered that the glial cell, which is a cell inside the spinal cord and the brain, activated, created inflammation, and started destroying tissues. And once it destroyed some receptors and tissues, the pain never went away. It became constant, became intractable. Now, they didn't exactly know why these glial cells were activating. The lead thought at the time was it was electromagnetic. But thanks to Watkins and her people, they thought it was autoimmunity, and it turns out they were correct. Okay? It was autoimmunity. They didn't know what was causing the autoimmunity. They just knew that these glial cells were activated. They wrote about it, they published it, but it got everybody's attention, like mine, who was in the field at the time. Now, a year later, a laboratorian by the name of Dr. John Belilo came to me, and he and I collaborated to do, in fact, the only blood studies on inflammation in adhesive arachnoiditis. Now, this wasn't a surprise to us, but we found out very clearly that people who had adhesive arachnoiditis had very high levels of inflammation. We looked in the research and we found out some interesting things going clear back into the 1990s. Some researchers had found that intervertebral discs were inflamed. The ligamentum flavum was inflamed. So inflammation of the spinal canal and the spinal cord wasn't really new, but we were able to document these things. So in 2016, we knew something. We knew that inflammation was throughout the brain and the spinal canal and the cauda equina and was causing really intractable pain. Now, I'm going to say something right here. And for anybody who doesn't want to hear what we're going to talk about here, doesn't want to hear about the new research, doesn't want to hear about viruses, doesn't want to hear about Ehlers-Danlos, I have a challenge for you. The challenge we had in 2016, 10 years ago, that was, where did the inflammation come from? Okay? Inflammation doesn't just show up one day like the mailman. It just doesn't appear. Something has to generate it. In 2016, we didn't know. And up until the last couple of years, we still didn't know. And so when somebody says, oh, I don't believe all this stuff that's going on or what have you, they ought to be asked a question. Where'd that inflammation in those intervertebral discs come from? Why do we have inflammation in the cauda equina and the arachnoid membrane? Why is there inflammation in the Tarloff cysts? Why is there inflammation around those small fibers that disappeared? In other words, we knew that inflammation was the culprit, but we didn't know why. Now, viruses at the time were a candidate, but also a lot of electromagnetic theories, which was the one I had, and I wasn't right. It was the other side was right, but I've certainly understand carried it on. So carrying on after 2016, here's what happened. That's when I decided somebody's got to go into full-time research on this issue. I decided to do that myself. My wife and we uh, had a lot of factors to move from just pure clinical practice into research, and that was about 10 years ago. We started the Arachnoiditis project about 6 or 7 years ago, and we've been plugging along, doing one study after another to get there. Now, without knowing exactly why a lot of these things, by the year 2020, we had figured out that you treated adhesive arachnoiditis with a 3-component medical protocol. Putting all the studies together, all the facts that we knew together. Now, that 3-component medical protocol still stands today. Now, let me go over it, okay? Everybody who's not only got adhesive arachnoiditis, but small fiber neuropathy, Ehlers-Danlos syndrome, pudendal neuropathy, burning mouth, whatever, there are 3 components. One, we know you have to suppress inflammation and autoimmunity. Number 2, we know that you've got to try to restore damaged tissue. The autoimmunity and the inflammation destroys tissue. And if you don't regrow it, it starts to scar, trap nerves, and then lead to a lot of complications, which I'm going to talk to in a couple of minutes. And number 3, you've got to control the pain. If you don't control the pain, you can't function, you can't work, you can't do anything, you can't even take your medicine right. And so these 3 components still stand today, half a decade later. And I don't see them going away. It's just that we're refining how to do something within those 3 components. That even includes such things as diet, sleep, exercise, psychological therapy. It includes a lot of things within those components, but those are the 3 fundamental components. Now, one of the things that just came out of our deterioration study, we didn't have enough subjects to make firm, definitive, enduring conclusions. But one thing was pretty clear. Those people that weren't following those 3 components weren't doing very well. Okay? They had to be doing all 3. Now, they could have different methods, different measures, different doctors, different approaches within the components, but the components were firm. If they left out one of them, if all they were interested in was getting their pain medications, they didn't do very good. If they decided they didn't want to take any hormones, they weren't going to do any very good. So, on the other hand, there were some people in our studies that did quite well. Now, we're going to hear in a few minutes from somebody who was in the study, and she can give you some of her own renditions. She's been a big help for quite some time to us, incidentally. Now, a couple of other things that came out of this study that I want to emphasize, and it's new, but it does answer some questions that I've had for years, and that is people who develop fibromyalgia, and then their arthritis, and then their intervertebral discs, their AA, their Tarlov cysts, and what have you. It turns out that we've talked about causes in the past, but it turns out that the causes of these conditions that lead to intractable pain are not singular. There are multiple causes. And in fact, it's a chain reaction. It's a pathological pathway, if you want to use medical terms. And it starts with what we call risk factors. Okay? Risk factors. Not causes so much. For example, people will say, I got adhesive arachnoiditis because I had an epidural. That's not quite right. The epidural was sort of a catalyst, if you will. People will say, well, I caught adhesive arachnoiditis after I had an automobile accident. That's not quite true either. That's a step along the way. Bottom line is, I'd like for everybody watching this You might want to take notes. There are what we call risk factors or pre-existing medical conditions that lead to the autoimmunity, the inflammation, and the intractable pain disease. Okay, let me go over these risk factors for you. One is, which I know a lot of people have out there, is a genetic connective tissue disease. The most common one, of course, is Ehlers-Danlos syndrome, but there's also Marfan syndrome, what they call hypermobile spectrum disorder today. But you have a genetic connective tissue collagen defect, and that's genetic. You've had it since birth. That puts you at risk factor. A risk factor doesn't say you're going to get something. It says you have a mathematical high probability that you may get something. It's a mathematical statement, really. Okay, genetic connective tissue diseases. A second genetic issue that comes to bear in people are they have an anatomic structural defect of the spine. These are people who have scoliosis, that's the major one, but they may have spondylolisthesis. They may be born with some kind of a cyst or tumor inside the spinal canal. But people who are born with a genetic anatomical defect of the spine are at high risk to develop adhesive arachnoiditis. A third almost genetic condition are those people who have what we still consider a genetic autoimmune disease. The most common one is rheumatoid arthritis, but a lot of people who develop adhesive arachnoiditis have ankylosing spondylitis. Some have lupus, some have psoriatic arthritis, or maybe a rare autoimmune disease. So 3 medical conditions are considered risk factors: a genetic connective tissue disease, abnormalities of the spine, and thirdly, an autoimmune disease. Now there are some other things you aren't born with that puts you at risk to develop adhesive arachnoiditis. I'm going to cover these. And they, one is diabetes. Okay. Turns out, for example, and we'll hear more about this, viruses love sugar. Okay. Just bank that one. Just start with that and end with that. They love sugar. They grow in glucose. Okay. Now, there are the things that we have now learned is that the viruses reactivate under conditions of stress. Okay. Now, I'm not talking about the stress of driving down the freeway or the stress of your overdrawn bank account or having an argument with your kid or anything like that. We're talking about a biologic event that goes on for several hours or days or months that elevates your cortisone and your adrenaline. Okay. It's that biologic, that hormonal change brought about by the stress that does the damage and allows the viruses to reactivate. Now, what stresses are we talking about? The most common one is trauma. Okay. Automobile accident. You fell off a ladder. You got hurt defending our country in the military. You had an unfortunate domestic fight. But it's also medical procedures. Every time a woman delivers a baby, that may be enough stress to cause some of this. Epidural injection, surgery, unnecessary injections. So medical procedures may be that stress, like an epidural, that puts you into high risk. So trauma, accidents, including medical procedures. Number 2 risk factor are severe infections. Now, all of us grow up with colds and with poison ivy and simple infections. But some people, even when they're children or teenagers, may have a severe infection like meningitis or pneumonia or infectious mononucleosis. Now, if you have any of those infections, even when you're a child, they may put you at risk to develop adhesive arachnoiditis when you're 40 years of age. Okay? So you got to remember one of the things about what we've learned. The time frame between the stress And when you know you've got a disease, it can be a long period, and it can be asymptomatic in between. All right. There is another thing that is a little surprising. I guess it isn't surprising, but psychological stress, mainly post-traumatic stress disorder, PTSD. But other people undergo severe stress in their lives, divorces, death in family, bankruptcies. These things can be very traumatic, and frankly, there are some psychological problems that'll raise your cortisol and adrenaline just as much as will meningitis. And so psychological stress can reactivate the Epstein-Barr virus. Okay, so that's one of the risk factors. Now there is another risk factor, and that is a contaminant inside the spinal canal. Okay, and contaminants inside the spinal canal introduced by spinal taps or epidural injections or surgery. They're usually medical. But if something gets inside the spinal fluid, that puts you at very high risk to develop adhesive arachnoiditis. Now, a few years back, we had a terrible problem with fungus, contaminated fungus, and epidural injections being injected into the spinal fluid. I got into this whole business when they used Panopake, a toxin, to do MRIs. That was a contaminant inside the spinal canal. At any rate, that may sound like a real doctoral lesson, and maybe it is. But everybody who's got one of these serious diseases does have to know what their risk factors were. You've got to know whether any of these problems are in one of your loved ones or your family or yourself. That's the essence of prevention. Do you have a risk factor? Identify them early. One of the nice things that's come out of a lot of this is that I now have a lot of parents very concerned about their children developing EDS or even what they have, and they don't want to see that. That's a very positive movement. There's a wonderful documentary out right now called Connected. It's about parents and who have EDS children. It's an excellent situation. Okay, now let's go on and talk about what may be the most revolutionary medical discovery of this quarter century, and that is that stress and these risk factors can activate the Epstein-Barr virus. It can also perhaps activate other viruses, and I will say a word or two about other viruses in a minute. But the Epstein-Barr virus is the one that's the quarterback, the leader of the pack, the real bad guy that leads the others. Now, Epstein-Barr virus, again, that's known as the kissing disease. A lot of people don't take it serious. All of us have it. It's ubiquitous on this planet. You acquire it normally when you're an infant, before you're age 2. It comes into your body through your nose or your mouth. You can wait till you're a teenager or a young adult and get infectious mononucleosis. That'll bring it into the body. But when you bring in the Epstein-Barr virus, what it normally does is go into the membranes of your throat or into your lymphocytes, which float around the blood. Now, it enters these two tissues, and under normal circumstance, it's a parasite. We all are carriers. We carry it in our lymphocytes. It's harmless. It doesn't do anything. And virologists like to say that it's in a dormant or latent state. Okay? I call it a carrier state, a quiescent state. Doesn't make any difference what you want to call it, but it's just there. It's doing nothing. And it's accompanied by other viruses and other parasites inside the body. Now, it just sits there and does nothing. But if you have one of these risk factors, one of these preconditions, and then get stressed, it reactivates. Okay, reactivates. Now I've got bad news on what happens during reactivation. Okay, it happens, and a lot of you watching this, I don't need to tell you what's happened because you've now experienced it. When the virus reactivates, it first off forms antibodies to try to protect itself from the virus. That's the body's natural protective response. But two other things happen with this virus. One is it forms what we call autoantibodies. Autoantibodies attack tissue. The second thing it does, the lymphocytes carry it to certain tissues and the virus infiltrates the tissues. It likes to infiltrate small fibers, small nerve fibers, the arachnoid membrane, the intervertebral disc, the fascia around your muscles, likes to particularly invade soft tissues. Okay? But let's talk about autoantibodies. Autoantibodies are what gives the disease rheumatoid arthritis its bad joints. When you have lupus, that's what gives you your rash. When you have Hashimoto's, that's when autoantibodies are ruining your thyroid. When you have psoriasis, autoantibodies are ruining your skin. But autoantibodies, here's what they do. They literally are like Pac-Man. They attack and attach onto tissue. They literally start chewing up the tissue. They start digesting it. And then you get inflammation. And if you don't stop the inflammation, you get scarring and nerves die. What's that mean? Pain, paralysis. Okay. Your bladder doesn't work. Your bowels don't work. Your sex life doesn't work. Your feet start burning. Your mouth starts burning. Okay. So what I want everybody to know and why this is so serious is that when that virus reactivates, it gives you autoantibodies and it infiltrates your tissue. It does both. And you've got to have a program, a 3-component program to tackle it. Okay? So that's the bad news. The good news is, even just the study we just finished and a lot of others we're doing, we're figuring out what to do about it. For just a real quick thing, somebody here among the show wanted to know what doctor they should see. All kinds of doctors are now jumping in, infectious disease specialists, rheumatologists, neurologists. I will say this, the medical profession is coming on board with this in some areas, and with some doctors, they're getting very aggressive. I've got a list of 6 or 8 new treatments here in the last month the doctors are trying. We don't know which ones are going to be the best, but we do know certain things. Now, let me talk about the next thing. It's complex. And I'm trying to teach doctors and patients and families about this real fast. We normally recommend that 3 tests be done to determine the presence of Epstein-Barr autoimmunity. Now, there are 2 antibody tests. One is against the membrane or the capsule of the virus. It's called a viral capsid antibody. And then there's also the nucleus of the antibody. That's just the inner part of the round cell or the round part of the virus. And that's called the Epstein-Barr nuclear antigen antibody. Now, when the virus reactivates, the antibodies go up. Okay? Now, the laboratory and science has figured out that a normal human being that's not sick, just an ordinary person who's not ill, if you take their blood, you'll have some antibodies to the Epstein-Barr virus in their blood. They have normal levels. Now, most of the laboratories today use a technical system that cuts off at about 20 or 22 units. So if you're above that level, you have got autoimmunity probably, and you may have some infiltration. We now have people on record that literally have antibody levels so high the laboratory can't test them. They're above normal laboratory testing. What that means is that these people have had several reactivations. Okay? So what I want you to know, and we're going to have to shift to our guest, but the virus does its dirty work by two methods. Autoantibodies, which is autoimmunity, and secondly, infiltration of the tissue itself. And I'll just close this off. You've heard a lot about us talking about peptides and hormones, exercises and diet. A lot of that is to build that tissue up so the virus won't grow in that tissue or you drive it out. Okay? So that some of these things are possible. Okay, we're going to shift on from this very serious discussion, but it is very serious. And I regret that this is not a medical show to tell everybody that little self-help and just read your Reader's Digest and your Epic Times and you'll be fine. Now, I'm sorry. It requires aggressive, competent physicians and caring families and patients that are willing to take on the self-care role. Serious stuff. All right. I'm looking for Allison.
I'm here.
You're here. I see
I'm
that.
here, Doc.
All right. How you doing?
I'm doing all right. I'm actually getting over a cold this week.
All right. Allison, first off, you're in Alabama, right?
Yes, I am.
What town are you in Alabama?
Center, Alabama, Weiss Lake,
Is that
way
on
northeast Alabama.
northeast Alabama? Uh, is, I was raised in a lot of small Kansas towns, my wife and I. How big is your town?
Oh, Lord, I don't even know. Very small.
Very small. Uh-huh. Were you raised there? That's your life? Been your home?
No, this is where we retired to.
That's where
We spent most of our life in Georgia, northwest Georgia. So this is only 45 minutes away from there, but Alabama is a whole different state. It's quite medical care. There's hardly any general doctors here. They're all nurse practitioners. Makes it really hard. Yeah, I have great faith in internal medicine doctors. They see a lot, out of the box and can see bigger pictures than just a regular family practitioner or a nurse practitioner. So the whole state is very unmedicated for lack of proper care, for sure.
Right. Well, I know a lot about you, and I know that you have taken care of yourself. Otherwise,
Yes,
you wouldn't be on this show.
that's true. I don't believe I would still be here. That's for sure.
Yeah.
I was in bad shape 4 years ago now.
4 years ago. Now, let's go back. When were you diagnosed with arachnoiditis?
4 years ago, thanks to you. But I had all the symptoms of it since at least 1990, and my grade 2 spondylolisthesis wasn't diagnosed until 1995.
So that was one risk factor you had, the spondylolisthesis. Do you have any of the other risk factors?
Have an appointment with a geneticist, Dr. Kendall, in Alpharetta, Georgia, coming up, and had to get all my records in sequential order, which took me forever with intracranial pressure lows and highs. It's hard to work or sit at the computer and try and get everything organized and condensed, but we're pretty sure that I have Ehlers-Danlos syndrome, and all 3 of my children have symptoms as well. So that's my biggest goal, is me to get diagnosed so we can connect it to my children so that they can get help quicker.
Now, can you bend your hands back, and do you have the hypermobile extension of your joints?
Not anymore. I'm so ate up with arthritis from head to toe. I used to be able to put my palm of my hands flat in front of my feet, like back in high school days, playing softball and everything. So, and in so many doctor's appointments, they were, I always had normal range of motion, even with the grade 2 spondylolisthesis and spinal contractures and all of that stuff. I would always have normal range of motion. So I guess nobody ever caught on to the possibility of Ehlers-Danlos syndrome going on.
Well, I don't think doctors knew much about it in those years. I didn't.
Yeah, true.
Up until 10, 12 years ago, it was Greek to me.
Right.
That was pretty typical of most doctors. We just didn't know. Thank goodness we do now. How old were you when you first got sick? You either had pain, you ended up in bed, an infection.
I did have infectious mononucleosis in 9th grade in high school. My back pain was long before that, though. I started seeing a chiropractor when I was probably around 8 years old for low back pain, and he'd throw my back out and throw my sacroiliac joints out, is what the chiropractor would say, because I was very active playing soccer and softball and tournament tournament ball and started varsity first baseman for softball. So I was always very active, but nobody ever recognized, I guess, the hypermobility that I had going on. So
you grew up with pain starting at about age 8. You had infectious
yes, lower
mononucleosis,
back
spondylolisthesis,
pain.
and EDS.
Yes.
Yeah, and you're still with us.
Yes, and years and years of too many years, about 15 years probably, seeing a pain management doctor that wasn't very compassionate and was just doing the normal epidural steroid injections as the arachnoiditis moved, even from my lower back to my neck. And now it seems like it's in my brain as well, as my neuroinflammation raises up, and I have to do a Toradol shot earlier than my 2-week game plan because the cranial pressures get so high. That's my clue that my neuroinflammation is getting too high. So I believe it's in my brain at this point too, which, I mean,
When you think, get this a lot, how do you know that you're getting the head pressure and either the pressure's up or the inflammation's up? How do you know that? What do you feel? Tell us about your symptoms?
oh, just a massive headache. Can't, like, my brain just hurts and my eyes hurt. It feels like like I'm wearing a ball cap and it's on too tight. It's strapped down too tight around my head. Noise, very, very sensitive to noises and to light. So I'll go to bed and put earplugs in my ears and face mask on and just lay there for hours because I can't do anything and certainly can't sleep through the pain, but I'll just end up taking a Toradol shot. I'm blessed that my primary care doctor, has followed your lead with your 3-component protocol and has been more than willing to help. I do my own Depomedrol injections, my own Toradol injections. I switched pain management doctors from the one that was doing all the epidural steroid injections and facet injections and sacroiliac injections and everything else to one that is very much more compassionate. I begged the old one to give me a different muscle relaxer like Soma, not knowing that was going to help with GABA replacement at this point. But they absolutely would not give any kind of diazepine drugs with opioids that they were prescribing. So I was able to change doctors that is very much more compassionate and willing to work with me. Plus, my primary care doctor has labeled me and signed off on paperwork that I am in palliative care. So my pain management doctor has that on file as well.
That's so. Now, two very questions. And Dr. Ibsen, I wanted you to come in on this next thing. One of these things I want to ask. One is the only thing you've found to help your head problems or your pressure problems is the Toradol and Medrol? Is that the only thing you found that helps? Or have you found other things that help?
The acetazolamide helps, but sometimes I have so much leakage around my surgical spinal fusion site because they had a bone growth stimulator put in there with wire leads for years and years after my second surgery to the same spot. They had to do a revision. So I believe I'm like, I don't feel down there. It's pretty much paralyzed. I don't have much feeling, but I will feel the burning pain, like there's CSF fluid there burning it like acid. So I don't really know.
Are you able to get a benzodiazepine now along with your opioids?
Oh, yes. I
Oh,
take Valium, 5 milligrams, usually 3 to 4 times a day, as well as Adderall, 5 milligrams, 3 to 4 times a day. Your intractable pain, Chronicle number 88, you held it up a few weeks back. Chronicle number 88 with all the different neurotransmitters. I carry that. That's part of my medical package that I carry in my purse. One, in case a cop stops me for whatever reason and questions all these medications I tote around in my purse. And if I have to go to an emergency room or something, I have an entire packet with all my diagnoses, adhesive arachnoiditis, intractable pain syndrome, and why I am taking all these drugs. Because even my latest rheumatologist questioned why I'm taking Adderall, and it controls my blood pressure. But
Yeah,
when I was on blood pressure medicine, I was actually going into pre-renal kidney failure because my blood pressure was dropping lower. Now that they finally got my pain under control, thank you, Lord, then my blood pressure was going too low. So I came off of the lisinopril, and my cardiologist and my nephrologist and my primary care doctor are all in agreement with my blood pressure logs that the Adderall is absolutely controlling my blood pressure.
yeah, they all think it's going to go up with the Adderall, don't they? But
Yes.
That's not true. When you have a deficiency of dopamine,
Correct.
you're actually you're substituting for the dopamine is what you're doing, and that'll
Right,
lower
because
your blood
all of mine, I'm sure I know my GABA and my dopamine is absolutely wiped out. I mean, I'll get to clenching my teeth and just subconsciously not even knowing it, and I'll get laid down and take 5 milligrams of Valium, and within 10 minutes it's stopped.
Mhm. And the other thing that you told me, which I wish I could get everybody to understand this, is that your primary doctor has said you need to be in palliative care. Therefore, your pain doctor will recognize that.
Yes.
Everybody who has adhesive arachnoiditis needs that letter from their
Yes.
primary doctor. Do you, and you carry your records around all the time. That's
Yes.
great.
I carry them in my purse because you never know what's going to happen, even just a car wreck or something. They have to know what drugs I'm on, and I have it listed out what drug I'm on, what dosage I take, and why I'm taking it.
Yeah, Dr. Ibsen, are you there?
I am.
Yeah, Mark, we're hearing something here that you're in contact with so many of these desperate people. Can we clone Allison here somehow? What do we?
Yeah. Well, thank you for your story, Allison. It's really moving what you've been through.
Yeah.
And it's also inspiring to see that you're still here. I have a question for both you and Dr. Tennant, and that is, Dr. Tennant, how come so many people with adhesive arachnoiditis or Ehlers-Danlos syndrome or previous adverse childhood events or any other risk factors that you pick or choose from, how come so many people are ultra rapid metabolizers of opiates? Is there a link that you've come across?
Yes, absolutely. And we haven't talked a lot about these cytochrome P450 abnormalities. But one genetic defect is always connected to another. And somehow, and this is where I wish they would take this serious, and people would take this metabolic problem more serious, because there's disconnects in the cytochrome. If you've got EDS, you're probably going to have an abnormality in some cytochrome P50 thing, and as well as in allergies and food sensitivities, you're going to have these things. And so, and rather than, and what everybody wants to do is deny that these things exist, but they do exist. And the guff we've taken, I do think that I did one of the very first studies on cytochrome P450 studies in intractable pain patients, and we found that everybody who needed over about 500 milligrams of morphine equivalent all had some cytochrome defect. That was all part of it. And trying to convince people that they might need more medication because of a genetic metabolic defect is just anathema. I'm mystified as to why the rejection over genetics having anything to do with disease. Okay.
Right.
Yeah.
Yeah.
Well, that's what I don't believe that I'm a hyper metabolizer. I was under medicated for so many years. Even after my revision surgery, I was on Flexeril and 5 milligram Lortabs, and then 5 milligram became 10, and then the 10 became, or 5 milligram became 10 milligram Norcos, and that went on until just 2020, when I finally went to my primary care doctor, because everyone was like, it's your back, you're seeing a pain management doctor, that's who you need to talk to about it. Let them handle it. But I was on my knees crying, begging, and pleading, and she immediately put me on baclofen instead of Flexeril and put me on Valium. And even now that my spinal contractures are no longer, of course, my muscles are atrophied and I can't stand up for 10 minutes without having to lay back down now because of it. But those two drugs immensely helped me, where the pain management doctor I was seeing at the time refused to change anything. But I had a total knee replacement in February of 2020, and like an idiot, let them talk me into doing spinal anesthesia for it in February of 2020. And then the pain was so bad, that's when I was on my knees in my primary care doctor's office begging her to figure it out. And then I Googled, why am I going paralyzed? And I found arachnoiditis with Dr. Tennant. And pretty much the rest is history. And I'm still here, as Dr. Ibsen says.
Wow.
Allison, you've done some writing. You're a good writer, quite frankly. Were you a journalist at any time, or you just
No,
were a good student of English?
I've always been told that I had quite a ways with words. So, because my children had a lot of special education needs in school, and I had quite a few fights with the school board and the school superintendents and stuff, and was always told I had quite a way with words. But and I am
Mark, are you listening?
I am Dr. Tennant. I swear I'm ready to mail off my history packet to the Ehlers-Danlos geneticist lady, and I'm going to get onto that bulletin for people who are just being diagnosed with spinal canal inflammatory diseases, so we can try and get the general practitioners or the orthopedics or neurosurgeons or got such egos. I don't know that will change their attitudes, but to get them on board there's no need for an epidural when I can take Depomedrol as a shot. You don't need to put it in intrathecally. So I want to do that. I will do that bulletin, because my husband's in that boat at this point in time.
Okay, one other thing we haven't covered. Tell us about your Epstein-Barr antibodies.
Oh, Lord, they're through the roof and have been for 2 years now, I guess, since you and I first started talking about it. The one was 648. the first year they were able to put a number on it. And then the last 2 years, when they checked it, it's just greater than 600. So they can't even put a number on it. So.
Mhm.
Dr. Tennant?
Yes.
So at what, I know this is all new stuff and
Yeah.
we're making it up as we go, but what would you suggest would be the appropriate level of viral activation or other variables to decide whether an antiviral is indicated or not?
I'm so glad you asked this, because this is very confusing, and I've got a recommendation, but it may change. But let me give you my thoughts at the present time. She has high antibody levels. Now, when I got into this, I thought those antibody levels would come down with treatment. They do not. The antibodies are there for protection, so the body is not going to bring those down. Now, the third test is for reactivation. Okay. Now, I know this is very confusing, and I'm not quite sure how we're going to get this across. In your case, you've got both antibodies very high. This means that you've reactivated several times in the past, maybe 10 times, maybe 100. We don't know. We just know that based on those levels that you have and the pain you have, that you've activated at least in the past, and you've got autoantibodies now, and probably in your case, you probably got rid of the infiltration. The antiviral medication at this time, I'm recommending it when you take the test and show there's current reactivation. Okay. Yeah. Now that's a third test, and it's very confusing. It's a new test, and I don't know that you needed to get started. So, Mark, at this point, I'm recommending that before they start the antivirals, they try to get the early Epstein-Barr nuclear antigen test. Now, if that's positive, we've got doctors out there trying all the antivirals. We've got more than one in some cases. They're trying ivermectin, homeopathy, methotrexate. They're doing a lot of different things. And I'm not sure that's going to be one of the things about our next study. In fact, we'll try to have people go get the reactivation test. So unless they have active current reactivation, I haven't been recommending the antivirals. But before you, and what I also want to caution people about, somebody's going to come along and say, well, let's just go in the classroom and test every kid in here, or let's go to the movie theater and test everybody here for Epstein-Barr. No, it should be a clinical diagnosis. You should have pain in at least 2 spots, and then as well as a viral test, so we don't mislabel anybody. Because I think as time, and when you study it as much as I have, I regret to say, the more I study it, the more afraid of it I get, the more concerned I am about it. It's almost like these viruses are the bane of human existence. They're there to kind of eat away our DNA, because that's what they are. And incidentally, the other viruses, herpes 6, cytomegalovirus, COVID, and the bacteria Lyme and mycoplasma, they all seem to enhance Epstein-Barr. They kind of are a team, and and the more of them that are active, the worse you are. So, but anyway, Mark, maybe you and I could get a little short educational piece that before you start the antivirals and some of the ivermectin and some of those things, maybe you want to get the test to find out whether it has reactivated. Now, even if the antibodies are high, you're still going to have to try to suppress the autoimmunity. And that's where your Toradol and your methylprednisolone, your quercetin, and some of your natural stuff, monolaurin is very popular today, comes in. So bottom line is the protocols for how you deal with Epstein-Barr is up in the air. That's where we need some research at this time, quickly and desperately.
Yes.
So, but the doctors are jumping in. I will say that. Yeah. And,
there's a question in the thread about would it cause any harm to be on an antiviral? And I'm thinking, Well, there's lots of people who are taking antivirals to suppress herpes simplex reactivation,
Yep.
and there's no particular side effects to that. So it seems to me that I would have a low threshold to prescribe something that doesn't have much in the way of side effects. Is that agreeable?
Well said. There's nothing wrong with a 30-day trial of Altrex or
Acyclovir, yeah,
Aclavir or Famvir. There's three of them.
yeah,
And
yeah.
any doctor who wants to try it. Now, some of the infectious disease guys, they're putting on two or three at a time of the antivirals.
Okay.
Wow.
Some of your infectious disease people are more concerned about this than I am, which is hard to believe.
Yeah.
But I'm not critical at all. I'm just glad to see we've got good doctors jumping in, giving it a go. And incidentally, ivermectin is starting to show up as a very good drug against Epstein-Barr, and it's labeled for parasites. It doesn't have the controversy it did with COVID.
And I
Yeah.
know from veterinary medicine, it's a very safe drug as well.
Sure, yeah.
So
Yep.
I don't know what the dose is for human dosage, but like in my dogs for heartworm preventative monthly, I use the cattle and swine product, which is like I don't know, a 10,000 times overdose compared to the drug you can buy at the veterinarian's office. But when you have a whole herd of dogs in your family, you go to cheaper route. So,
The
but
maintenance dose.
I did also try the valcyclovir, and it did affect my kidneys. So it can cause glomerulonephritis. So if somebody has an underlying autoimmune disease that they're not aware of that might cause interstitial nephritis or glomerulonephritis, which Epstein-Barr virus itself can cause glomerulonephritis, you make sure you keep an eye on your kidneys taking the antivirals.
Yeah.
Thank you.
Teresa Larson has just signed in, and her ivermectin is 14 milligrams. Most people have been taking something like 10 to 14 milligrams for 5 days, 10 days, and then switch it over to a maintenance dose of 3 to 6 milligrams twice a week, something like that. So I don't know that you want to take my dosages right now. Just a lot of people are trying different ones, and
Yes,
we'll figure out the best dosages coming up. But
that's great. That's why I called you with my latest diagnosis of limited scleroderma, and the doctor put me on methotrexate. Scared the daylights out of me. I wasn't starting it until I called you and asked you if I could.
We're about out of time. We'll talk about methotrexate another day. But if you have high antibody levels, there's nothing wrong with trying the methotrexate. A lot of German physicians are having very good luck, and we're having some luck now in this country. So
Yes.
Trexate is a cover because it treats autoimmune diseases. It's a drug been around a long time, and so it's very good. Well, we're about out of time, but this has been just great. Allison, you've been wonderful. We need to
Thank you.
We need to get you duplicated and your message quadrupled. Mark, you got any last words for us on this most exciting interview? Or
God bless us, everyone.
Yes, God bless.
Yeah, and all right, let me close out. This is exciting because for us to come up with a protocol, we need people and doctors and nurse practitioners and pain specialists to try things. Let us know what works, and then we'll get them out there somehow. Okay. With that, Jamie,
Okay.
again, good station. Mark, thanks so much.
Thank you.
Allison, you've been super as usual. We'll sign off till next week. Good night.
Thank you.
Thanks so much. Good night, everyone. Thank you all.
Love y'all.
You're not alone. Love you all too.
Thank you, Jamie.
Thank you
You're
too.
awesome.
You're awesome too. Good night, guys.
Good night.
Body.
Night.
Good night.
Good night, everyone.
Pain
Good
ward.
night.
We gotta love one another.
Good
Guys.
night. Good night, y'all.
Night, everybody.
Good night.
Love you guys.
I love you.
Love y'all.
Good night.
Night.